We have two great speakers today. Our first speaker will be Prasanna Ananth, and she's from the pediatrics department here in Hem-Onc, and she's going to be talking about improving end-of-life care quality for children with cancer. So.
Have to lower that microphone to fit me. Thanks everyone for the opportunity to present my work at Cancer Center Grand Rounds. So today I'll share with you a little bit of background on my research and give you a little bit of context on why research on end-of-life care for children with cancer is important. I'll describe some of the groundwork for my current research and then share with you the results of a qualitative study in which we explored how do stakeholders define high-quality end-of-life care for children with cancer. So despite a number of advances in treatment for children with cancer over the past couple of decades, cancer remains the #1 cause of disease-related death in children. Each year, a little over 15,000 children are diagnosed with cancer, and 80 to 90% of these children are cured long-term. But 1 out of every 8 children will not survive their disease. So this is estimated to be around 1,900 children every year who die. Why study end-of-life care for children with cancer? Well, we know that kids with cancer have limited access to palliative care and hospice resources, and there's really a dearth of empiric data out there. Most studies are plagued by very small sample size and utilize administrative data, which have its limitations. In general, studies using patient-reported outcomes are very scarce. One such study conducted by my mentor, Joanne Wolf, looked at symptom burden in children with advanced cancer. And I know that the print is probably a little bit tiny to see. But what this indicates, so on the x-axis is symptom prevalence. So these were all children at multiple centers who reported on their symptoms. And what you can see here is that even in an era where we have a lot of therapies for symptom management and access to palliative care, children with cancer continue to experience substantial pain. And so this blue bar represents high distress, so symptoms that cause a great deal of distress in patients. You can see a whole range of symptoms that are highly distressing to children with cancer. What this indicates is that there's substantial room for improvement in care of these children with advanced cancer. We previously conducted a study using the Pediatric Health Information System database, which includes data from over 40 US children's hospitals. We looked at over 1,200 children across the country with a range of chronic conditions. So children with cancer were included in this cohort, but weren't the only children herein. Ages 1 to 18 years who died in the hospital in 2012. What we specifically examined was resource use of the hospital, including hospital days spent in the intensive care unit, and costs of care, as well as major medical interventions, so things like mechanical ventilation or operations. While the intended purpose of the study was not necessarily to compare children with cancer to the overall cohort, I put these data side by side just to give you a little bit of a sense of how children with cancer compare to other children with serious illness. What you can see is that children with cancer have more frequent admissions to the hospital and a higher total number of hospital days in the last year of life. And overall, not surprisingly, also accrue greater hospital costs as a result. We looked at care received in the terminal admission, or the admission in which these children died. So for children with cancer, what we found was that about a quarter received some form of technology assistance in this terminal admission. So this included placement of tracheostomy tubes or gastrostomy tubes to help sustain health status. Over a third underwent operations. Over half were mechanically ventilated by this admission. And 3/4 of children had an unplanned admission that ultimately resulted in death. So we concluded from this national study that children with cancer have a high burden of hospital resource use in the last year of life, and that most children in this cohort spent at least 1 month in the hospital in their last year of life, whereas children with cancer spent at least 2 months or longer. Moreover, it appeared that major medical interventions like mechanical ventilation and operations are quite frequent in the terminal admission. What does the literature say? Well, it turns out that the subsequent literature actually supports these findings in that a majority of children with cancer throughout North America appear to receive intensive services near the end of life. This includes frequent use of the emergency department, the intensive care unit, the hospital, and across the board, low rates of referral to hospice. But really, the question that remains unanswered is what constitutes overly intense end-of-life care? We really have no idea about the preferences and values of children and their families. So this was the core question driving my research going forward. What really defines high quality or good end-of-life care for children with cancer? So in order to talk about this further, I'll just share a little bit of background on what we use to measure quality. So quality measures, as defined by the National Academy of Medicine, are tools to evaluate healthcare structure, processes, and patient preferences with the goal of delivering patient-centered or better care. Measures can be developed by any number of stewards and then are submitted to organizations like the National Quality Forum for endorsement. There are a range of measures in palliative and end-of-life care, that's what this graphic represents, that are mandatorily reported by hospice agencies. But a lot of these measures, and actually are then subsequently tied to reimbursement, but the vast majority of these measures in hospice and end-of-life care are explicitly exclude pediatric age patients. So I'll share with you some adult quality measures in the cancer context and why we have unique considerations for children with cancer. So for example, it's generally considered good care to avoid death in the hospital for an adult with advanced cancer. Whereas we know from anecdotal evidence and from prior research that patients and parents may prefer in-hospital death, either for comfort of the child or respite for the family. Similarly, for adults with cancer, it's generally considered good care to enroll in hospice at least 3 days prior to death. But we know, even from our state of Connecticut, that hospice availability or the capacity to care for children may be very limited. So we conducted a qualitative study involving a range of stakeholders with two primary objectives. The first was to explore stakeholder priorities in caring for children with cancer near the end of life. And then second, to examine whether existing quality measures for adults with cancer are relevant to kids. This study involved 54 stakeholders across 2 sites, both Yale and Dana-Farber. We started out with 2 provider focus groups, so one with physicians and one with non-physician providers last fall, and then also conducted a number of interviews over the past year. We included 12 bereaved parents, 4 providers in these one-on-one interviews. And then sort of a novel aspect of the study was that we also sought to interview adolescent and young adult patients and parents of children who have advanced cancer. So this was defined as metastatic disease or cancer that had progressed beyond the initial diagnosis or was incurable. And I think this really adds a valuable perspective in that a lot of the published literature examines the perspectives of bereaved parents. It's definitely difficult to engage bereaved family members in research, but in some regards, involving a bereaved parent and talking about the care that their child received at the end of life when the worst has already happened is somewhat easier than talking with a patient or parent who is facing advanced illness but hasn't sort of thought about what the circumstances might be in which they'd like to die. Our interviews and focus groups were all audio recorded, transcribed verbatim, and inductively coded, and then we used grounded theory to analyze the data. So just to give you a sense of demographics, this is a qualitative study with a small sample size, and we used purposive sampling. So we tried to get a range of perspectives, trying to include some mothers as well as fathers in the study, a range of racial and ethnic backgrounds, and children with a variety of diagnoses. So I'll share with you now some of the recurrent themes that we saw from our qualitative analyses and the ways in which these themes either aligned or didn't align with existing adult quality measures in this context. So our participants spoke to us time and again about the importance of direct communication with their child. only a few bereaved parents reflected on not wanting to have a conversation with their child about the end of life, in part because of age-related considerations. But in general, patients, parents, and providers alike all talked about wanting to have developmentally appropriate conversations about what the end of life might look like. All of our participants talked about the importance of interdisciplinary team involvement, using chemotherapy if it has the opportunity to relieve symptoms, honoring family preference for location of death, whether that be home or hospital, and access to the hospital or emergency department for some aspects of care. In all of these cases, these measures are different from what is generally considered good end-of-life care for adults. So, for example, in the adult context, generally, there is a preference to avoid death in the hospital, but we know from our study, and I'll share with you some specific quotes that attest to this, that there are some benefits to being admitted to the hospital. A lot of our participants talked about the importance of symptom control, specifically pain control, avoiding intensive resuscitation, so avoiding mechanical ventilation or CPR at the end of life, and then the importance of hospice referral, although we did elicit a number of misconceptions about hospice that I'll share with you. So in regards to direct communication with the child, a number of participants talked about this. One parent said to us, if the child is coherent, I think that it's really important to hear from the child in regard to their wishes and what they want. And a patient said to us, a child might not understand that they're going to die, so I think it's important to explain to them in terms that they'll understand what's going to happen. I think the takeaway here is that age-appropriate anticipatory guidance is clearly very helpful, and in not all circumstances will we be able to sort of explain in full what's happening to a child, but there clearly is value placed on having some sort of communication directly with that child and not just with the parents. Not surprisingly, a number of our participants talked extensively about the importance of an interdisciplinary team. So this included incorporating the input of nursing staff, our psychosocial clinicians, child life, even hospice representatives. And all of our participants talked about how important that is, how everybody has good ideas. Interestingly, in terms of chemotherapy near the end of life, our participants did underscore that they felt that chemotherapy may offer some measure of symptom relief and satisfaction for parents that no stone was left unturned. So generally speaking, I think as providers, we have this perception that we don't want to continue to offer enrollment on early phase clinical trials if it's really clear that this patient is dying. But our participants really said that there may be some utility, whether that's for the coping of the family or for relief of symptoms. So one bereaved parent, talked about how for them, there wasn't an option, or at least they didn't perceive any other option. Chemotherapy is what we had to do in order to save my child. Interestingly, it didn't turn out that way, but I don't have any regrets. In terms of hospital use near the end of life, I thought this was really interesting in that I think we have a lot of preconceived notions about where people want to die, and a lot of adolescent patients talked about not wanting to spend too much time in the hospital. But on the whole, what our participants really told us was that there may be some resources available in the hospital that can't be provided at home, that a lot of times children have needs that extend beyond what home nursing can provide or what hospice services at home can provide. So one bereaved parent told us, personally, I wouldn't have been able to take care of her at home to the extent that she needed to be taken care of. A provider told us, avoidance of death in the hospital, again, I don't think it's a good marker because we have many families who say that they are scared to have their child die at home for either them or for the child or for siblings. They don't want that in the house to be a memory. And so again, I think it's a very personal decision. So clearly the takeaway here is that having the option of hospital use is valued. And then in regards to symptom control, interestingly, all our participants really talked primarily about pain and not about a whole range of other symptoms. But one bereaved parent said to us, my #1 priority is just for her to be comfortable and pain-free. And then a patient said, you want to keep them out of pain and in a place, where they are comfortable in the last moments of life. So clearly assessing and relieving pain is highly important. And then in regards to avoidance of intensive resuscitation, a provider said to us, avoidance of mechanical ventilation at the end of life is very relevant. It's a temporizing measure. A bereaved parent then said, CPR wouldn't be for the child to revive them to be in more pain. That would be from a parent who can't let go, I think. So with some exceptions, there were a few parents who talked about how it's really sort of patient or family dependent. But apart from those exceptions, in general, participants preferred to avoid CPR or mechanical ventilation if possible. And then in regards to hospice, as I was saying earlier, we elicited a number of misconceptions about hospice. So one adolescent patient said to us, I feel like hospice is a symbol almost of end of life. I don't think it's a place that kids should ever have to experience. And this was sort of a recurrent theme throughout that some of our patients and parents had never really been spoken to about hospice and needed some orientation as to what hospice is and what it has to offer. About half of the bereaved parents involved in our study actually had utilized hospice and spoke very positively about it. One provider then said, I think we are very limited as to hospice agencies that are comfortable providing for children. And I think that Connecticut is a really good example where we have just 2 hospices across the state that can offer any resources for children. And I can count on one hand the number of nurses who feel comfortable taking care of children who are dying. So we have real pediatric limitations in terms of hospice resources. So while it may be nice to refer children to hospice, we can't always guarantee that hospice services will be received or that families will receive the extent of services that they desire. So what we found in our study was that patient and family-reported quality measures were clearly very important. So this included direct communication with the child, involving an interdisciplinary team, and controlling symptoms, and that we really ought to honor family preferences for a location of death. Interestingly, there were a number of healthcare utilization measures that were elicited here. So the importance of offering chemo if used for symptom relief, allowing for hospital or emergency department visits if there's some benefit in terms of symptom control or respite for the family, facilitating hospice referral where hospice resources are available, and then avoiding mechanical ventilation or CPR. I think the big challenge here with patient and family reported quality measures is that these data are not consistently reported or collected in any fashion. Whereas some of the elements of healthcare utilization can be obtained through administrative databases, there is actually a lot of components here, like hospice referral, that we actually can't necessarily accurately obtain from an administrative database. So this really kind of underscores the importance of having novel tools for collecting these data, whether those tools are natural language processing or development of an instrument that's systematically administered. We really don't have any standards in this context for end-of-life care and don't consistently collect any of these information from our children who have advanced cancer. All right, so I moved a little bit more quickly than I anticipated, but I'd just like to acknowledge my amazing mentorship here and at Dana-Farber, an incredible interdisciplinary research team that's really helped us conduct this research across 2 centers, and all of the support both at Yale and externally through foundation grants. And I'll end here and welcome your questions. Yeah, so I'll give you a really specific personal example in terms of how health insurance has an impact. So what I'll say is that children with serious illness, a lot of times they'll have private insurance, but also be eligible for supplemental Medicaid. And so when their private insurance stops paying for some component of care, oftentimes Medicaid will kick in. But just to give a really specific example, we recently took care of a child with advanced glioblastoma in the hospital. And after he had been in the hospital for a couple of weeks, I was on the phone with an insurance company kind of arguing for wanting to keep the child in the hospital. The family wanted to stay in the hospital. This child had a lot of care needs that couldn't be accommodated at home, and they didn't feel comfortable going to a hospice facility. And so, I spoke initially with a private insurer, then we realized that the patient had supplemental Medicaid insurance, that kicked in, but ultimately I think that family will be responsible for paying for some component of their in-hospital stay. So I think that's a huge limiting factor here, but largely because of this notion or this assumption that that some of the same care that can be provided in the hospital for someone who is dying can be provided at home, and we know that that's not true.
Is there typically or ever counseling available for parents or siblings of patients that might help? I'm sure this is a very emotionally fraught process, and I imagine that it's also somewhat age dependent with the patient as to how one deals with this. So any insight on that part?
Yeah, so we do actually have standards for psychosocial care of children with advanced cancer, and most centers around the country have access to child life specialists, social workers, or psychologists. The resources are really limited, but every child at our center is assigned a psychosocial clinician, as well as they engage with child life. Enrollment in hospice has one added benefit in that there are bereavement services that are offered to families for 6 months to a year after the child dies, and that can be accessed by the parents, by the siblings. A lot of hospitals around the country don't have formalized bereavement programs or ways to sort of continue to support bereaved families afterwards. Carrie.
Can you speak a little bit more about some of the policy barriers with regard to hospice use? For instance, in adults who are enrolled in hospice, that based on your findings, where some of these people do want to be in the hospital or do want, or I won't restart, but or do want to receive cancer-directed therapy, are policies a barrier to that for kids in hospice?
So interestingly, with the advent of the Affordable Care Act, there was a provision for concurrent care for children. So what that allows for is concurrent illness-directed therapy and enrollment in hospice. I think practically speaking, a lot of hospice agencies do still, I think you still have to be sort of within the last 6 months of life estimated. And I think that can be really challenging for children because the trajectory of illness can vary. And we do have an option, for example, at Yale of virtual hospice, where a child can be admitted to the hospital and have sort of the same nursing staff, the same attending provider, but would have the addition of a hospice nurse. But what I've heard sort of practically speaking about that virtual hospice option is that virtual hospice agencies are also selective about who they admit to their hospice. And so not everyone who necessarily wants hospice will be admitted because there's costs associated with it. Aaron.
I have a microphone I'll bring down because it's hard to hear in this room. Okay.
All about transfusion support, whether families wanted that. That's certainly been a limitation for the hemoglobin patients to go into hospital.
So we didn't ask specifically about transfusion, but some bereaved parents who were enrolled in hospice talked a lot about transfusions being a reason they would want to come to the hospital or want to come to the emergency department, because that can't be provided in a hospice setting, and often can't even be provided necessarily in clinic.
Yes, thank you. The attitude and the demeanor of the parents affects the child significantly. If the parents are distressed or sad or in front of the child, it doesn't help. Are the parents getting any counseling here at New Haven Hospital? Do they have access to psychosocial help like the child?
Right. So this was a challenge actually that some parents described, in that they had mental health needs, and our team is there to support the whole family, but the trained psychosocial clinicians on our team are really intended to support children and siblings, I would think. So, for parents who were really struggling, who needed prescription medications to help with coping or anxiety, they had to be referred to outpatient resources. And some families reflected on that being very difficult when their child is actively ill or dying, having to go outside the hospital for therapy or pay out of pocket for those resources was really challenging and something that was often neglected.
I'll take a turn. Thank you so much for this talk. I just want to acknowledge for those of us who don't hear these stories a lot, I can only imagine that some of this is overwhelming to hear what the experiences of parents caring for these very sick children. And as a parent myself, just thinking about that. So thank you for bringing this. I think your comments about where patients want to die is really important. So, we make this distinction between adults and children, but I would make the argument that many adults would choose to die in the hospital if they could really understand the trajectory and the care needs that are involved. And for the caregivers, the family caregivers too, sometimes the hospital is the right place. And so just to add that to our thinking about, how do we think about the best end of life care and what a good death can mean to different families.
Mm-hmm. Yeah, I didn't mention this earlier, but those measures that I described for adult cancer are really hotly contested. Not everybody agrees with using those metrics to assess for a good death.
In the studies that we're looking at, when we asked Americans where they want to die, most people say at home. But